Presenter, Dr. Smrithi Sony.
Next presenter, Arpita.
Next presenter is Arpita. You're there? You're ready? Okay. Fine.
Shall I begin, ma'am?
Yeah, please.
Yes, ma'am, that's the first slide. As I delve into my topic, I would like to bring to your notice an entity known to all of us, but may probably not have pondered much about. This is the Heinrich Safety Pyramid, which shows the link between the volume of accidents causing significant, minor, or no injuries. But why bring this up here? Merely because I would like to pose an analogy with ophthalmology, wherein certain diseases, if detected early on at this stage, would narrow down the number of irreversible visual loss cases at this stage. And here comes one of the most important assets in our quest to tackle visual loss. A very good afternoon to one and all present here. A 17-year-old girl with no significant medical history has been on regular follow-up at a primary eye care vision center since 2019 and was consistently prescribed glasses where she took up full correction. However, during her visit to our center in the year 2022, the vision center technician noticed a significant decline in her uncorrected vision. Her right eye dropped to 624 and the left eye also showed a similar decrease, which improved to 6/6 with adequate correction. By her 2023 visit, her vision had worsened further, dropping to 6/60 in both the eyes. Importantly, in these visits, her anterior segment examination remained normal and the fundus showed no significant anomalies. However, during her 2024 visit, while her uncorrected vision remained 6/60, the right eye only improved to 6/18 with correction. This prompted the technician to evaluate the fundus, during which blurring of the disc margins was noted. Given this finding, we referred her to the base hospital for further evaluation. At the base hospital, all routine investigations were proved to be normal, and the fundus findings from the vision center were confirmed here. An MRI of the brain and orbits was conducted, revealing a heterogeneous, brilliantly enhancing lesion from the posterior segment of the right optic nerve, which was suggestive of an optic nerve glioma. Given the small size of the lesion, the oncologist recommended regular follow-up and to follow up for a biopsy if there was any progression in the future. Whole body scans taken months later proved uneventful. Her recent visit a few months prior revealed a decrement in vision by one line, but the patient was otherwise asymptomatic. Optic pathway gliomas primarily affect children under the age of 10, accounting for 3 to 5% of childhood CNS tumors. 71% of cases occur in the first decade and 90% by the age of 20. Many patients with optic pathway gliomas, particularly those with neurofibromatosis, are asymptomatic. When symptoms do arise, visual loss is the most common, regardless of tumor location. And this is often accompanied by relative afferent pupillary defects, field defects, and color vision deficits. Typically, fundus changes suggest optic atrophy, but in our case, the disc swelling was noted, probably because of an earlier diagnosis. Dodge classification typically categorizes optic nerve involvement as stage 1, but was excluded in our patient. Its management depends on tumor progression and visual acuity loss. As defined in a study, progression is marked by a loss of 2 lines in a Snellen chart. As our patient showed no progression, in 6 months, no treatment was recommended. The risks of biopsy outweigh the benefits, and regular follow-ups are planned to monitor progression. Our patient initially had a gradual vision decrease attributed to refractive error, but was later diagnosed with a different cause at a vision center. Thanks to our advanced telemedicine system, continuous connectivity between the ophthalmologist at the base hospital and the patient was maintained, enabling timely referrals and effective management. Ongoing training and updates in investigative techniques further support these technological advancements. To conclude, this case demonstrates how a thorough clinical examination, even in a primary healthcare center, can uncover serious unexpected diagnoses like an optic nerve glioma. If not for our well-trained vision center technician, much damage would have been done to the girl's sight, and the girl would have lost out on her vision and her future. This underscores the importance of regular follow-ups and detailed clinical evaluations as facilitated by vision centers, which aid in accessibility to quality healthcare. A superficial correction of a presumed refractive error could perhaps mask what lurks deep within. Thank you.
Thank you. A very good presentation.
Thank you, ma'am.
So, what was your basic aim of presenting this case? Was it to show the trajectory of how from the community we can get the cases and treat them, or was it basically how we are going to treat after knowing the optic nerve glioma?
I wanted to highlight how if we have focusing on well training our vision center technicians, even at a primary healthcare level, where there are people who are not able to access good ophthalmic healthcare because they are posted far, they stay far away from a tertiary healthcare center. Even with the help of vision care centers, we are able to train them enough, and early diagnosis of such conditions can stall it at an earlier stage, so that if diagnosed earlier, we can constantly monitor
for that part, it is very good. You are giving a thing that we should get to the community and get this
Yes, ma'am.
cases to be done. But coming to your base hospital, what will be your treatment planning or algorithm when you are finding this optic nerve glioma
Yes,
now
ma'am.
at your center?
Yes, ma'am.
Yours is a tertiary center.
Yes, ma'am. So at a tertiary care center, first we would localize where the lesion is. And then based on the size of the lesion and where it is located, we will check for progression. So usually in these cases where there's primarily just a vision care-
Be very basic to your case, because I don't want your case was there. In that, what was the next prognosis in these cases?
Yes,
Did you
ma'am.
refer to a neurosurgeon? Did they any excision, or it's not a biopsy every time, but did they go about or a chemotherapy in these cases, or you are just following the case up?
In our case, we initially waited for a 6-month follow-up. Prior to that, we had gone to an oncologist. He suggested a biopsy or a chemotherapy if there was any sign of progression. So since there was just a visual acuity loss of less than 1 line, after 6 months, we had done no intervention per se. So we will monitor for progression, ma'am. And if there are signs of progression, that is in this case, if there is at least a 2-line loss of visual acuity, we would intervene by chemotherapy, because in biopsy, considering the location, it would be more risky than the actual benefits of a biopsy. Yes, ma'am.
Very nice presentation.
Thank you, ma'am.
So, what's your protocol normally of following up these patients? How do you follow up these patients?
In such cases, we follow by 3 to 6 months. In our case, we stuck to a 6-month follow-up period. So initially this patient presented to us 6 months back. So the latest presentation,
So
we
what all
first
do you do in the follow-up?
we check for visual acuity, we check for field defects, color vision defects, and we can take an MRI if there is further progression. So by the baseline investigation,
You don't do MRI in all the visits?
not necessarily, ma'am. We check the financial constraints of the patient as well, ma'am. So here, since the visual acuity just decreased by 1 line, we told the patient to follow up after 3 months, and if we find further visual acuity loss, we would insist on an MRI, ma'am.
Thank you.
Yeah. So the the treatment part was just observe and follow up, right?
Yes, ma'am. as
Isn't
of
it?
now.
So do you feel that there are, since it's a telemedicine, talk that you're giving, there would be many more conditions where you can, do a justice, detect early and treat, isn't it?
Yes,
Of course,
ma'am.
this case was no doubt a very good case.
Yes, ma'am.
But there would be many more such ophthalmic conditions where you detect early
Yes, ma'am.
and prevent, fall of vision or blindness, isn't it? For
Yes, ma'am.
example, birth asphyxia,
Yes, ma'am.
isn't it? If you're in a tertiary, if you're in a peripheral center, and if there is a child, who is being delivered either with a forceps or with a vacuum or with a, everywhere I don't think for the delivery the doctors are available. So if Japa lady, what they call, if she's delivering the child, isn't it?
Yes,
The child can have, asphyxia, cause a brain damage, where you have to immediately treat, otherwise the child can have, cerebral visual impairment, cerebral palsy child, isn't it? So these are the conditions where acutely you need a management. But the case that you presented was just observe, wait and watch, isn't it?
Yes, ma'am.
Yeah, thank you.
Thank you, ma'am.